Good morning. My name is Tina Valentin, and I'm the Regional Stroke Education and Data Coordinator for the Regional South Stroke Network. We're pleased to present today's session. The topic is a scalability assessment of the transitional care stroke intervention in community stroke rehabilitation. Access to the recording and handouts will be sent in a follow-up email. A link to the evaluation will be added in the chat, and a QR code will be available also at the end of the presentation. Please add questions throughout the presentation to the Q&A at any time, as there will be an interactive component for about 15 minutes at the end of the presentation. In the follow-up email, you will also receive a certificate of attendance, so please add your name and save for future reference. I'd like to now introduce our speakers. Melissa Northwood is an assistant professor in the School of Nursing at McMaster University and co-investigator with the Aging, Community, and Health Research Unit. Dr. Northwood is an applied health services researcher and previous CIHR Health System Impact Fellow who conducts collaborative research through strategic partnerships with older adults and health and social care providers to improve the well-being of older adults. Dr. Northwood's research program seeks to enhance care quality, the culture of the practice environment, and health system transformation through a learning health system. Prior to joining the School of Nursing in 2020, Melissa had a lengthy practice career over healthcare sectors from acute care to home care, with a focus on older adults with multiple chronic conditions, including persons with stroke and their care partners. Tracy Chambers is a research coordinator in the School of Nursing at McMaster University. She holds a Bachelor of Science in Nursing and a Master of Science in Nursing from McMaster. For over 10 years, she has coordinated a number of research studies focused on designing, implementing, and evaluating innovative community-based interventions for older adults with multiple chronic conditions, including diabetes and dementia. I'll now turn it over to Melissa and Tracy.
Thank you, Tina. Hello, everyone. Thank you so much for welcoming us today to present at your rounds. And we're really looking forward to sharing the findings from our study and having a discussion with you all as well. Tina and I and the team are really hoping that you'll complete an evaluation of today's program, and we'll put up this link again at the end of our presentation. We do not have any significant disclosures or conflicts to share. We'd like to start with the land acknowledgement that McMaster University recognizes and acknowledges that we're located on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands that are protected by the Dish with One Spoon Wampum Agreement. And we encourage you across the province today to reflect on the lands where you are. So here are our main objectives for today's rounds. We're hoping to share with you information about the transitional care stroke intervention in community stroke rehabilitation, and then understand the factors that influence the scalability of the transitional care stroke intervention across 3 diverse community stroke rehabilitation programs in Ontario. So we'll just start with a little bit of a background of how we came to do this work. And as you're all aware, Ontario Health has been engaged in a multi-year project to enable a standardized, equitable, integrated, and patient-centered system of care that supports the recovery of people after stroke. Ontario Health has developed a community stroke rehabilitation model of care and a guidance document on navigation during community stroke rehabilitation that was based on best practices and patient and provider expert opinion. And at the same time, Dr. Maureen Markle-Reid, Professor Emeritus in the School of Nursing at McMaster University, who's also on our call with us today, who will join us during the discussion, was studying and designing the transitional care stroke intervention. And this is a complex patient-oriented intervention to improve the quality and experience of transitions from hospital to home and from formal services to self-management in the community. And the core components of the transitional care stroke intervention are well aligned with both the Ontario Health Model of Care for Community Stroke Rehabilitation and provides an example of how the principles of the model of care and the principles of the navigation document can be enacted. So we partnered with Ontario Health to conduct this research study.
So the purpose of the study was to assess the scalability of the transitional care stroke intervention and determine its readiness for scale-up with 3 community stroke rehabilitation programs in Ontario. The programs were selected to reflect diversity in geography, so urban, rural, and northern locations, hospital-based and home-based outpatient settings, and the presence or absence of a navigator role. To clarify, scalability is the ability of a health program that has been effective on a small scale or under controlled conditions to be expanded into routine practice to reach a greater proportion of the eligible population while still remaining effective. The transitional care stroke intervention was co-designed with experts and stakeholders in stroke care, including patients and caregivers, healthcare providers and managers, and policymakers. 2 pragmatic studies have examined the implementation of the TCSI and its effects in real-world clinical practice settings with existing providers, that is, in hospital-based outpatient stroke rehabilitation programs in Ontario. First, there was a small feasibility study, and that was followed by a randomized controlled trial. In both studies, the intervention was delivered by an existing interprofessional team of stroke rehabilitation providers. And both studies targeted older adults, so those 55 years of age or older, with stroke and 2 or more chronic conditions. The transitional care stroke intervention is a 6-month virtual evidence-based intervention that is patient-oriented and was designed to complement usual care provided by an outpatient community stroke rehabilitation program. Its goal is to improve the quality and experience of transitions by addressing gaps in transitional care for older adults with stroke and multiple chronic conditions. Its core components were based on best practices in stroke care. They were designed to support self-management, and they consisted of flexible and fixed components. The transitional care stroke intervention was delivered by an interprofessional team consisting of an occupational therapist, a physiotherapist, a registered nurse or registered practical nurse, a social worker, or a speech-language pathologist. One member of the team also served as a system navigator or care coordinator. In the randomized controlled trial, this was either the OT or the PT, but any member of the team can serve in this role. The foundational component of the transitional care stroke intervention is post-acute care coordination and system navigation by a designated care coordinator or system navigator. Other main components of the TCSI include post-hospital discharge telephone follow-up by the care coordinator within 2 days of hospital discharge to facilitate timely access to outpatient CSR program and to assess the needs of the patient and their care partner. Virtual home visits were conducted by a member of the interprofessional team. The first virtual visit was conducted by the care coordinator system navigator within 14 days of the patient's discharge from hospital. Monthly interprofessional team conferences were held to discuss patient goals and to develop a single interprofessional plan of care. And care coordination and system navigation support, such as facilitating access to primary care, home care, and community services, was provided with the support of an online resource called the My Stroke Recovery Journey website. The frequency and timing of home visits was flexible and tailored to the needs and preferences of the patient. The monthly interprofessional team conferences, care coordination, and system navigation were flexible components. The intervention was originally designed to be delivered in person, but was redesigned to be virtual because of the pandemic. Main activities during the virtual visits included conducting a comprehensive assessment of the health and social care needs of the older adult participant using standardized tools, using evidence-based guidelines to prevent and manage stroke and other chronic conditions and transitions in care, conducting medication review and reconciliation and supporting medication management using best practices, providing self-management education and support using a strengths-based approach, providing navigational support, such as supporting linkages and referrals to health and social service providers, supporting participants in using the My Stroke Recovery Journey website to navigate resources, assessing and supporting caregivers, and with the participants' consent, the team sent alerts to communicate and identify concerns to the primary care provider. The care coordinator or system navigator on the team proactively identified and addressed risk factors for adverse events, such as avoidable hospital readmissions or safety issues. They arranged community services for follow-up healthcare appointments, facilitated communication between the patient, their family caregiver, and the healthcare team, supported linkages and referrals to health and social service providers, developed and evaluated an individualized patient-centered plan of care in collaboration with the team and the patient, and continuously monitored and updated the plan over 6 months. And they served as a liaison between the healthcare providers and patients. And the system navigator and care coordinator also conducted most of the virtual visits. So, to provide a brief overview of the results of the randomized controlled trial of the transitional care stroke intervention, there was no effect of the TCSI compared to usual care on hospital readmissions or the frequency of use of emergency departments. However, participants who received the TCSI showed greater improvements in physical functioning, their ability to manage stroke, and the reported patient experience compared to patients who received usual care only. Patients self-reported their use of health and social services during the study, such as primary care and specialist visits, emergency department use, and medications, etc. And even when the additional cost of delivering the intervention was added to the total cost, there was no difference in cost of use of health services between the intervention group and the group that received usual care only. According to providers who delivered the TCSI during the trial, some factors that facilitated implementation of the TCSI included the dedicated care coordinator or system navigator, the use of standardized clinical assessment tools, which facilitated discussions among the interprofessional team and with patients and caregivers, and the use of alerts, which facilitated communication and information sharing between the interprofessional team and primary care. And the interprofessional team used SharePoint to communicate and share information before both sites had access to an electronic health record. Assessing the scalability of promising programs is important because many programs are scaled up without supporting evidence, and conversely, others with demonstrated effectiveness are not translated into the health and social care system. We used the Intervention Scalability Assessment Tool, or ISAT, to help us conduct a systematic assessment of the scalability of the TCSI with the 3 selected CSR programs. The Intervention Scalability Assessment Tool, or ISAT, has 2 parts. The first part is about the intervention or program itself, and the second part is about implementation. Each part has 5 domains, and the authors of the tool have created very helpful questions to guide teams through the assessment. Part A of the ISAT focuses on the problem, the intervention, the political context, evidence of effectiveness, and the intervention costs and benefits. And Part B of the ISAT looks at intervention implementation issues, such as if the intervention would have to be adapted, if it would be acceptable to the patient population and the teams that would deliver the intervention, what's happening in the delivery setting and workforce, the implementation infrastructure requirements, such as training, IT equipment, and human resources to implement the intervention, and if and how the intervention could be sustained over time. So these are the main processes that we follow during the scalability assessment. A total of 32 participants contributed to the scalability assessment, including CSR providers, rehabilitation program leaders, including managers and directors, persons with lived experience with stroke, and representatives of the Ontario Regional Stroke Networks. A working group was established in each of the 3 selected sites and included CSR team members and leaders, patient partners who had received care from the CSR program or were a care partner to a person with stroke, and representatives of the Ontario Regional Stroke Networks. We held working group meetings ranging from an hour to an hour and a half by Zoom to learn more about current practice within the program and how it compared to the TCSI, and to discuss factors that would influence the scalability of the TCSI in each program. We completed a total of 8 working groups over the 8 working group meetings over the life of the project. And during the final working group meeting with each site, the working group members rated the scalability of the TCSI by responding to readiness questions, which were adapted from the ISAT. The ratings for each question were totaled and averaged across participants, and the final scores for each of the 10 ISAT domains were used to generate a radar plot or a visual representation of the final scores by ISAT domain. The research team also reviewed documents such as CSR program documentation, assessment forms, referral pathways, patient-reported outcome measures, research literature on transitional care stroke interventions, best practice guidelines, and core health documents. We also conducted 11 one-to-one semi-structured interviews over Zoom or by phone with providers and leaders across Ontario with experience in stroke care and rehabilitation. And these interviews provided additional information to answer questions in the ISAT that could not be answered from other sources. 2 participants had been previously involved in implementing the TCSI. We also interviewed people outside the CSR team who might have insights into scalability, for example, hospital leaders who scaled up programs in the past. And finally, we analyzed working group members' scalability ratings and conducted a content analysis of the working group meeting minutes and interview transcripts to arrive at our results.
Thank you, Tracy. So now I'll take it from here and share the results. First, we thought we'd start by sharing the results that we found across all of the participating sites about the benefits to implementing the transitional care stroke intervention and some of the implementation facilitators and challenges. So the key informants and the working group members identified a number of benefits to implementing the transitional care stroke intervention as an evidence-based model, and that the core components, in particular, having that dedicated care coordinator or system navigator on the team, would really facilitate the outcomes of improved system navigation, enhanced self-management skills, and successful community reintegration. And they felt that that dedicated care coordinator system navigator role was very important to support the person with stroke at critical transitions, supporting their system navigation, providing that important continuity of care, And as this key informant said, reducing the risks of things falling through the cracks. Several factors at the system level and at the community stroke rehabilitation program level could serve as facilitators to implementing the transitional care stroke intervention. So at the system level, as we were shared earlier, the transitional care stroke intervention really aligns well with current Ontario health initiatives and some other ongoing work that could potentially facilitate improvement as well, including some provincial work on an approach to data collection and reporting in community stroke rehabilitation programs, Ontario Health's work on integrated care pathways, and also some potential with the reorganization of home care in Ontario. And of course, the Ontario Regional Stroke Networks are great assets. At the community stroke rehabilitation program level, the transitional care stroke intervention is consistent with the local priorities and some of the initiatives that they are undertaking already, looking at improving transitional care and system navigation. Some of the core components of the intervention are already part of usual care. And programs are more likely to be sustainable over the long term if they're adapted to the local context and population. So that can be a real facilitator. And some other existing resources that could help with the implementation of the transitional stroke intervention include access to regional or acute care stroke navigators in some areas of the province, established relationships with community supports and service providers, and potentially electronic health records that could facilitate interprofessional care planning, communication, and goal setting. But in some cases, they would need to be tailored to really fit with the community stroke rehabilitation program needs. So participants in this project also shared several factors that would negatively impact the scalability of the transitional care stroke intervention. And at the system level, this includes ongoing system integration challenges. So some of the silos that we have in stroke care services between healthcare sectors that are funded and managed separately can result in poor communication and coordination of care between community stroke rehabilitation providers and home care, primary care, and community-based services. And this is not unique to the care of persons with stroke. Participants also identified that in some parts of the province, there still is a lack of access to local and standardized community stroke rehabilitation. And not all of the rehabilitation teams are solely dedicated to stroke rehabilitation, and there are wait lists for rehabilitation services in some areas of the province. As well, the implementation and delivery of the transitional care stroke intervention would require increased human resource capacity at a time where participants were still under significant strain in the healthcare system due to a lack of health human resources across the province and including primary care providers. At the program level, programs shared that they would require additional and ongoing funding to support the implementation, the delivery of the transitional care stroke intervention. For example, initially having a project manager to oversee implementation, the additional human resources it would require to implement the navigator role, and then protected time for providers in addition to their daily work to deliver the components of the transitional care stroke intervention. And then provider time to follow patients for a longer period, up to 6 months. And also support to enact the virtual delivery of care, which would include training and equipment for staff and persons with stroke and their care partners. Education, training, and support for providers would also be required to achieve and maintain competency in transitional care, develop expertise in virtual care, and as well support a focus on strengths-based care. Finally, participants talked a lot about how a common digital platform would really facilitate and support their communication. and coordination. So there would be access to information among providers and importantly, between settings, hospital to home care to community services and to primary care. And as part of this, participants identified that standard metrics would be needed to monitor implementation and program quality. And we have a quote from a key informant here who shared that we've been learning from some of the different sites is that any kind of outcome evaluations that they're doing, it's that extra manual step for them to collect any kind of metrics to monitor the program. And most folks have been saying they'd love to have some sort of infrastructure that automated that and made it easier to see. Okay, so now we'd like to shift and share some of the site-specific results. So we had 3 programs, as Tracy mentioned, that participated in this study. One was a home-based program. The second site was a hospital outpatient program in a rural, remote part of the province. And then the last was a hospital outpatient program in a mostly urban setting that had an existing navigator role. So we thought it would be interesting to show you these radar plots. These are the visual representations of each site's rating of their readiness to implement the transitional care stroke intervention. And the rating is on a scale from 0 to 3, and 0 is at the center of the plot with not being ready at all to implement. 1 is to a small extent, then 2 is somewhat, and 3 is to a large extent. So that would be on the outer edge of that, the spider plot there. So if you look on the right side, you can see that the sites rated the need to enhance transitions in stroke care as important, and that the transitional care stroke intervention would be effective and is aligned with their program's strategic context. But on the other side of the plots, I hope it's the left one facing you too, but on the other side, you can see that the sites felt less ready in the areas related to their workforce and funding as well. So here is kind of a bigger view of the radar plot for Site 1. This is a home-based community stroke rehabilitation program. And you can see that their readiness for implementation overall was to a large extent. But again, you can see on the other side, they felt less ready in terms of their implementation infrastructure, such as funding for a designated navigator role, and then the concern about would there be long-term sustainability of that funding. So here, the program agreed that a dedicated care coordinator system navigator would benefit their program. And they had some great ideas for local adaptations for their context and the people that they served. The first was to use a stroke care binder, so a hard copy instead of a website to support care planning and system navigation. And this came strongly from the patient partners that were involved in the project. And they were using a lot of other programs to conduct core components of the transitional care stroke intervention. So for example, an acute care unit would conduct that early post-discharge call to check in on the person with stroke after they'd left. And then the community support post-discharge from their program was done with a community peer education and support group, and which the patient partners and caregivers also very much enjoyed. So moving along, here is the site results for Site 2, which again is a rural and remote hospital-based outpatient community stroke rehabilitation program. And you can see their readiness for implementation is lower overall. And this was mainly due to the human resource challenges and access to community stroke rehabilitation in more remote areas in their region. And at this site, they felt that a regional care coordinator was a better fit to support system navigation. So that person would be external to the community stroke rehabilitation team. And again, they had great ideas for adaptations. They felt that the kind of longer term follow-up visits rather than virtual, that might not work for all of the people that they serve. So a hybrid might work better with in-person and virtual. In their setting, they offered education group-based and did group-based goal setting. And they found that very effective rather than a one-on-one model. And like the first site, they leveraged other programs to provide support post-discharge from their rehabilitation program. And that's a community self-management program. And again, the patient partners really supported that model. And finally, at Site 3, this is an outpatient hospital-based program with an existing navigator role. So you can see again from the plot that their readiness for implementation is high overall, including their implementation infrastructure was rated as more ready than the other sites because of the existing navigator role. But their concern was longer term sustainability, given some unknowns related to ongoing funding. And they noted a real desire to work more collaboratively with Ontario Health at Home. So at this site, they felt that both a regional care coordinator outside of the community stroke rehabilitation team, in addition to the dedicated navigator role on their team, would really facilitate connections to the community and improve community reintegration for the people that they served. They also suggested some adaptations that would be helpful for their local context. Again, they in their program, they offered group-based education with a peer support component, and they would continue to do that. Instead of investing in adapting the My Stroke Recovery Journey website, they would leverage their existing databases of community programs for stroke that were well developed in their region. So to conclude, the participants shared many benefits to implementing the transitional care stroke intervention and the scalability assessment helped them identify facilitators and barriers to the scalability of the transitional care stroke interventions in 3 quite different community stroke rehabilitation programs. And we thought their ideas for integrating care and how to adapt the program and implement components of the transitional care stroke intervention could be helpful for other programs. The scalability assessment can be a useful tool to assess readiness for implementation, and even generating that plot provides a helpful visual for a team to kind of talk things through and see what would be the most important kind of critical next steps. And it is free for use, the scalability tool we used online. The link is in our references, which Tina will be sharing after the presentation. And it actually includes all of the rating questions that we used and a handy Excel document that makes that radar plot for you. We also learned that even evidence-based programs require adaptations to the local context and population. And the co-design of these program adaptations should be done locally with patient partners and health and community care providers and leaders and decision makers. And we found coming together in the working group meetings, all of these different perspectives really helped to understand what would work in the local context and what would need to be adapted. Really, Tracy and I enjoyed working on this project very much. The community stroke rehabilitation community, I don't need to tell you, has a wealth of knowledge and innovations to achieve integrated care. And yeah, we really enjoyed learning from you all. So we see a number of potential projects or next steps following from this work. As we said, we tried to select programs that were representative of different models of care across the province. So other programs may want to consider conducting scalability assessments and implementing the transitional care stroke intervention in their programs across the province. The key informants and working group members felt that virtual care had a lot of potential as a facilitator for transitional care, but required some work. So some programs use virtual care more than others. As we shared, the different community stroke rehabilitation programs thought that different models of navigation would work in their area. So for some, having that dedicated system navigator on the team, and for others, they thought having the navigator external to the team. So it would be helpful, I think, to understand what's the most effective model for what area. So that we could make some recommendations when people are considering augmenting that part of their program. We definitely heard this loud and clear, that a data collection and reporting strategy for community stroke rehabilitation is needed in the province and would be really helpful for teams to see the impact they're having at the program level, and also how their work is impacting stroke care at the provincial level. And it would be a useful exercise to build on the work that Dr. Markle-Reid did, and kind of collate and build an implementation toolkit for the transitional care stroke intervention to support implementation across the province. As I mentioned, we'll make our slide deck available, so you'll be able to refer to our references for this project after the fact. And I must acknowledge our research team, the team that went before us. You'll see Dr. Markle-Reid's team here, and she was funded by CIHR. And in our current study, Tracy and I are presenting on behalf of our team from McMaster, including some students, and we are most grateful to Ontario Core Health for supporting the current phase of our work. So thank you all for your attention today in the rounds, and we just want to say again a big thanks for all of the participants in this project. And I've got my email here, so please reach out if you want to get in touch, want to discuss anything that we talked about today. And we really look forward to the discussion with you all now.
Yes, thank you. Thank you very much, Melissa and Tracy, for your presentation. So please, you will see the evaluation link in the chat, and also the QR code on the screen. So please feel free to add questions into the Q&A or in the chat if that's easier. You're also welcome to put up your hand if you'd like to ask the question verbally, and we can allow you to unmute. Maybe I can just get started with a question. And so what would you say are the biggest lesson or perhaps lessons learned in this project?
Thanks, Tina. I think Tracy and I would agree that the importance of relationships, and we heard this both in the working groups and from our key informants, that where there were strong relationships across the healthcare sectors and into the community sector, they really felt that helped transitions for persons with stroke, and building those relationships are important, and they take time. And participants also shared that getting that buy-in, that transition management is part of everyone's role across the whole continuum. They also felt that that was really important, and that the person doing the system navigation was often the one that would help kind of bring everyone along and share the importance of knowing each other and working together on that journey with the person with stroke. And again, where those relationships were really strong, they felt good about handing off care or referring their client to a program in the community when they knew the providers and had that relationship with them. So it's teamwork, intersectoral teamwork.
Mm-hmm. Thank you. And one of the things I was wondering as I was listening, did any of the 3 sites continue with it, or how was it? Did it end with the project? What was the next steps for the sites that were involved?
That's a good question. I wonder if anyone's here and wanted to share. So how we left it with the sites is that we shared. Tracy took detailed minutes that we share with the sites, so they would have that kind of analysis of where they were at and what some of their goals were related to transitions in care. And also shared with them their radar plot. So all of the programs were already kind of working on goals for their programs. So we're hoping that in some way they were able to kind of build this into the processes that they already had in place. I know the sites without dedicated care coordinator system navigators were really hoping to see that investment for their program and build out that role.
Okay, thank you. There is a question in the Q&A, and Lenley is asking which sites are being evaluated with this process.
Thank you for asking. We were not able to identify the sites, tell you their name and location, and this is just based on how the agreement that we had with our Hamilton Integrated Research Ethics Boards and the sites participating ethics boards or governing structures where they didn't have an ethics board. So we didn't want to inadvertently identify a participant by sharing the site. So we were hoping by describing kind of the nature of the program and whether they served an urban or rural or remote population, that you might be able to draw some insights that were relevant to your own program.
Okay, thank you.
Melissa, I was going to ask a question regarding some of the challenges that were clearly identified by the 3 sites, and one being the funding consistency long term, and then the other being the infrastructure implementation. So recognizing those were a challenge, have there been any further discussion as to how to overcome that, especially recognizing that all we're talking about, a regional kind of care coordinator capacity beyond the navigator role. And in saying that, I just wanted to highlight in the chat that Denise said, since they participated in the study, we now have a navigator for their region starting in October, and very excited to looking into this in a further capacity. So that kind of lends a little bit to where I was going with my question, but I'm just wondering, knowing there have been these hurdles, and we saw them clearly even across all 3 sites. Has there been any dialogue about how to overcome that, or what possible next steps might be?
Mm-hmm. Thanks, Eileen, and that's great news. From what like our next steps for this project are to compile a report, which we'll be presenting to Ontario Health Core Health at the end of the month, and highlighting some of these implications and what we learned from the sites, and from what we understand from Ontario Health. They're very invested in ensuring that their model of care is enacted across the province. And in their funding models, they've been considering what best practice would be and should be, and what resources would be attached to that, rather than kind of status quo funding, if that makes any sense. So I think I think there is an understanding of in order to deliver some of these additional components that are beyond usual care right now, an investment is required. At the same time, we're hoping by cataloging all of the innovations that these programs are doing, that it could help other people see where there might be, I don't want to say an easy win, because none of this is easy, building relationships and creating care pathways, but there might be an opportunity to have another part of the stroke continuum pick up an important part of transition management, like the stroke prevention clinic, for example, as a support in the post-discharge kind of uncertain period, a check-in call to kind of help people along in their journey.
There's also a question in the chat. Is there any sort of mandatory prep training for patients and family regarding acceptance and preparation of home care interventions? I feel that patients are very unprepared and surprised when we approach them to the home care visit, including intercultural, gender-related factors, language, gender, etc. And this comes from Marco.
That is an excellent question. That is an excellent question. With our, I wish the program was here and could answer, but I'll do my best to answer on behalf of what I learned from them. What really struck us, because the program shared information with us so we could learn about their programs, including what they would share with their patients in the community. And the home program had this fantastic, now it's hard copy, but a fantastic document that was included in a binder that traveled along with the person from acute care into the home, and included a picture of every single team member and who they were. And so when they were knocking on the door, they knew, oh, this is my physiotherapist. So it was kind of that handoff, or the baton pass from acute care to the team, that made them feel that was more seamless. But you're right, these periods of transition, our patient partners shared that there's so much information is coming at you, and there's so many changes in your physical health and your mood and just your processing. It's hard to keep a handle on who's coming and what role they're playing. So Marco, I hope that answered your question in some part.
Thank you, Melissa. Selden has asked a question. Who did you identify as the key person or persons to help facilitate communication and coordination between hospital and the community for patients and their families? In our rural hospital, we currently have a team, but I would say communication and coordination is lacking.
Mm-hmm. The key person. Yeah, so the from what we learned from the teams, ideally there would be a key contact person on the community stroke rehabilitation team who would be that point of contact for the person with stroke. However, we learned that identifying that their partner in the community was challenging. And this is where we have some optimism. We're hoping with some of the taking a fresh eye and a new look at home care, that there might be an opportunity to better integrate at that local level. I might ask Maureen. I don't know if you wanted to comment on that or the previous question.
Sure. Thanks, Melissa. So I think one of the key facilitators for implementing this model of care is having very strong collaborative interprofessional relationships, but also, as Melissa mentioned, having strong partnerships with the community. And so in our trial and our feasibility study, significant time was invested by the team in learning about those community resources and developing relationships with key home care provider or key providers within those organizations. So that was really, really important. And so going forward, I think it's important to invest time right up front to build strong relationships with relevant community partners.
Thank you. Eileen, were you going to?
No, I was just going to say, Marco says thank you back in the chat, Melissa. So it seems that you did address some of what he was looking for.
Okay. Yes, thank you. So we have a few minutes left. If someone would like to add a question into the Q&A or the chat, or again, feel free to raise your hand. So here we do have a question from Kilu. For the CSR program that you analyze, do they offer home visit service as well? And if so, how did they differentiate? Oh, it's Kelvin. How did they differentiate their service with conventional home care services?
Yes, thank you, Kelvin. The one program that was involved was an entirely home-based program. And because of that, they had really strong connections with home and community care, now Ontario Health at Home. And they actually were able to leverage that and some of the other services from home care. For example, the rapid response nurse. So if they needed support, they really were in partnership with home and community care. So it was very complementary, but that was by intention and design and relationships they developed with their that program over time.
And Selden says, thank you to Maureen. I love the idea of involving the community and its resources. Marco has an additional question. In my practice, I see that patients with persistent chronic pain have difficulty reaching out to MDs to implement strategies for managing it. Is there any specific avenue to help us professionals guide the patients back into those resources in a timely manner?
That's a good question. Maureen, I'm in your...
Yeah, I was just gonna mention that one of the challenges we faced in the trial was, and the team faced, was connecting with primary care. And so one of the things we implemented was what we call an alert. So the team would complete an alert if they had concerns about a particular area, and they would send that with the patient's permission to the family physician for further follow-up. So I think this is an example of something that could be used to address this issue. And similarly, I think that there's room for improvement in terms of collaborating with primary care and along with the community services that I mentioned earlier. So I think that's an area for improvement, definitely. And I'm glad that you raised that because it's such a huge issue with stroke. Rehabilitation pain is a huge problem. And so perhaps that's something that could be considered in the future as an element of the intervention.
Thank you. And Kelvin also has said thanks. And again, Marco has noted a thanks. A question from Athena. Who facilitates the group education for patients and families where this has happened? Don't know if you're able to answer that.
Yes, sorry, I
Oh,
was
you
I was
did?
typing away in the chat to Athena, and then I realized it only loops back to us. So on the teams with their education offerings, a member of the team would take a lead on a particular topic based on their expertise, and they also involved community providers as well, like someone from the March of Dimes to talk about community support services. So it was kind of like a program, like a curriculum almost of weekly topics during the time people were in the rehabilitation program.
Okay, well, I'm going to lead into a question that actually mentions March of Dimes, and from Suzanne, it says, great presentation. Wondering if you explored partnering with third sector stroke support organizations, such as March of Dimes Canada, who have a personalized navigation model in place within Ontario.
Yes, I'm so glad that you raised that, and I apologize if that did not come out loud and clear in our presentation. That those programs where they were available were absolutely vital. That the expertise of the community resources and that reassurance, the community stroke rehabilitation program was handing off that warm handoff, that care to that community-based program was essential to support the community reintegration piece.
Okay.
Yeah, and that we had one patient partner is coming to mind who just raved about about that program as well.
Okay, we have a question here. Are other stroke networks working on a process similar to this? Are you able to give any insight to that?
Could you clarify that? I think there was a number of different stroke networks involved in this project.
Okay, so we can see if there's any other further clarification on that question.
Yeah.
Okay, and we are just about out of time, so I want to say thank you again to Melissa, to Tracy, and to Dr. Marco Reed for your special presentation, your special attendance. And thank you also to our audience. And as a reminder, there will be a link to the evaluation in the chat and as you exit the webinar. The next provincial round, stroke rounds, is scheduled for October 2nd. The Northwestern Ontario Stroke Network will be presenting on making stroke education fit for purpose, priorities and approaches for educating healthcare professionals. So we'll hope that you'll be able to join us at that time, and have a great day.
Thank you. Thank for welcoming us into your community.
Yes, thank you very much again.
Thank you.